All right, great. Thanks, guys. Thanks for the invitation. So some of these talks obviously led right into this pretty well. So pedal arch reconstruction, it sort of makes sense, right, with the angiosome concept, the last mile delivery problem. So it's sort of like Amazon getting all your packages to the local station, but not to your doorstep. And so, again, delivering to your doorstep is what we want to see. We saw some data earlier, along with this rendezvous trial, showing that in direct flow may be better than indirect flow in terms of wound healing. Of course, that doesn't necessarily take into the presence of collaterals. So again, really no guideline recommendations until maybe recently, where there's a little more angiosome, inline flow that was supported. But mainly clinical indications, advanced Wi-Fi or CLI classes, and again, it's sort of the ultimate argument for angiosome-based concept. The problem is, as Stephen was saying, is that more and more these days, because of diabetes, kidney disease, advancing age, we're seeing patients with X-rays like this and calcium, and so. When I get a duplex in these CLI patients, I definitely look at the outflow, and if I see dorsalis pedis or plantar vessels that look like this, I have much more confident, I tell the patient much more confidently that we're going to be able to help them and set some expectations as opposed to potentially needing multiple procedures or DVA. But these are the patients that really can benefit potentially from pedal arch reconstruction. So it really goes back to just good technique, knowing the anatomy, taking good angiography and good wire catheter technique, I think, and then having sort of distal access techniques to bail you out. Again, so high quality angiography, DSA with delayed images. You really want to see collateral flow. You want to stay on that pedal. Multiple views and the right views. Using 018, sometimes even 014, but usually 018 support catheters to get really selective and injecting with a 3 cc syringe. Sometimes simultaneous injections with 2 support catheters or popliteal and a support catheter, and being aware that 10% of patients have tibial anomalies. Here's just some for reference for anatomy. These are the views that you really should try to get take in standard views. So an orthogonal view where you split the lateral medial plantar artery, you see the arch in one view, and then a cranial unfossed view where you see the sort of figure 8 of that dorsalis pedis going into the perforating artery and that to the lateral plantar artery to get a relationship of the anatomy. So again, anatomical variance, very common, 10% of patients. Pretty easy to tell when the vessel is nice and open. So here's some just examples. You can see dominant perineal arteries supplying the DP, PT, or even the entire pedal circulation. But when these are occluded and your wire is not doing the right thing, it's something to think about. Here's an example of a popliteal injection on the left, showing what looks like occluded, DP, distal DP and lateral plantar artery. But when I put an 018 catheter in and inject through that 018 catheter, you can see that the arch is actually open, just diseased. So here's an example of just a support catheter all the way in the arch, 014. And through these injections, you get sort of different pieces of the puzzle sometimes of the plantar arch. And so you just have to put it together and figure out what the arch looks like. So here, injection with a lateral plantar, and then within the arch itself, we assumed that this was what the arch looked like, even though it looked a little strange from this angle. But indeed, it did look like that. And so here was the before and after. A fairly good result with some, hopefully effective digital flow. Potential wire choices, typically 014 hydrophilic wires. This list for me hasn't changed in like 8 years. The Fielder XT is, I think, a wire to have available. It has a 009 tip. It's very delicate, so you don't want to use this to really get to the pedal arch. But once you're there with the support catheter, it allows you to navigate the little branches because it maintains selectivity. So you put a really bend at the very tip, which it allows you to do. And even in the smallest arteries, it doesn't straighten out, so you can still steer around. Similar to techniques that you do in the SFA or any other artery, true lumen crossing doesn't work. You can do retrograde lumen, knuckle wire technique I use a lot, cart, reverse cart, double balloon technique, and then again, distal access. So instead of tibial, ankle access, you may have to go to the digital access to bail out. So here's just another example. Again, important staying on the pedal. To watch those collaterals fill, and you can kind of see, I don't know, right down here, you can see that arch filling late. So in your mind's eye, you have to kind of know where these vessels should run in the anatomy in both views, and you need to move back and forth sometimes because you might think that you're in the arch, and then you go to a lateral view and you're entirely in the dorsal view, trying to get into a lateral tarsal artery instead of the lateral plantar artery. Here's just a looped wire technique. So again, 014, keep the wire loop small. And just same thing that I do in the SFA with an 035 system, I'm doing in the foot in an 014 system. Here's an example. The wire is bunched up subintimally both ways, so we basically use a balloon to do a cart technique, and then you can see the wire from the posterior tibial lateral plantar artery is able to traverse into the contralateral tibial vessel to get through and through access. And so again, you can get perfusion to the digits effectively. Obviously patency is another issue, but you can get pretty good technical success. Here's external ultrasound being used. So again, you like to see the artery that's calcified on the outside is fine, but the inside you want to see not, what we call the white stop sign, where that's portends a pretty poor likelihood of success. So just, what we want to connect, we can use ultrasound to even see if we're in. Here you can see the wire is subintimal. So we access digitally. You can see this is very typical train track calcification of the digital metatarsal artery. So that's the artery, the needle coming in, blood. Here we thought we were going to go right into the catheter from above, but it was subintimal or past each other, so we did 2 balloons here. This was many years ago. I think 1 balloon is enough if you ever need to do this. And then that allows it to fenestrate, and the wire is able to connect and open that arch. Just some other examples of sticks that can bail you out. So again, train track calcification you see here. You see as I back out that V18 is it goes into the vessel. Here's an example of sort of an anomalous arch. The dorsalis pedis is just non-existent, so you come down, and but they have decent lateral plantar arteries. So not able to get to the posterior circulation through the anterior circulation because of the anomaly. And so we hit the medial marginal. Medial plantar artery. I'm thinking DVA. And able to get across. Here we did we do CSI? I think we lasered, actually. Lasered and got a good result. So, and just some other examples of distal access. Thank you.